Welcome, dear audience. My PhD topic is about improving postoperative outcomes after cardiovascular surgery. My name is Nikolett. I'm a specialist in anesthesia and critical care. I work at the Városmajor Heart and Vascular Center, and my vision is for science to prevail over routine. And for that, I would like to implement standardized perioperative protocols in cardiovascular anesthesia to minimize postoperative complications. These are my specific goals. My first one is regarding cardiac surgery, and the second one concerns vascular surgical patients. My first project is investigating the predictive value of urinary biomarkers in cardiac surgery-related acute kidney injury with the methodology of systematic review and meta-analysis. It is known that acute kidney injury develops quite commonly after cardiac surgery, and its recognition is essential because we still don't have specific treatment options. Urinary biomarkers have been widely investigated in several critical conditions to identify patients who are high risk for developing acute kidney injury, but we still don't know if urinary biomarkers can accurately predict the development of cardiac surgery-related acute kidney injury. So our aim was to define their accuracy, because if we are able to identify patients who are in the risk of developing kidney injury, then we can implement specific clinical measures to decrease the development. So we worked with adults undergoing cardiac surgery, and our hypothesis was that the urinary biomarkers are able to predict the development of AKI after cardiac surgery. We performed a systematic search and arrived to have almost 90 articles. We were not able to retrieve 3 articles. Here you can see a small section of the basic characteristics table. We performed a quantitative analysis on 79 articles, including more than 12,000 patients, and they reported on 11 individual urinary biomarkers. So I'm going to show today the pooled AUCs of individual urinary biomarkers, the combination of two or more biomarkers, and also the predictive ability of clinical models enhanced by urinary biomarkers. So on the first table, you can see the individual biomarker prediction for all and severe AKI cases defined by the KDIGO criteria at different measurement time points. We performed subgroup analysis based on merged measurement time points of these urinary biomarkers. You can see that individual biomarkers can only provide fair accuracy for the prediction of AKI. On this second table, you can see more urinary biomarkers. This table shows the individual prediction for all stages of AKI and severe AKI cases defined by all criteria with the same subgroup analysis with merged measurement type points. You can see that the highest AUCs are also in the fair accuracy range. On this next figure, you can see the combination of biomarkers for prediction of severe acute kidney injury. You can see that they can provide higher accuracy. We are in the good prediction range. On this second figure, you can see that the number of the combined biomarkers does not affect the predictive accuracy. So clinically it's not useful to use more biomarkers than 2. We had enough data to assess the predictive ability of established clinical models, and also the clinical models enhanced by urinary biomarkers. There is an increase of the accuracy if we use biomarkers together with clinical models. However, this difference is not statistically significant. So let's see the strengths and limitations of this study. It's a comprehensive study investigating not only individual but also a combination of urinary biomarkers and clinical models. It's a relatively homogeneous population because all of them are on cardiac surgical patients. The limitations is one of the limitations is that we had to merge the measurement time points of the biomarkers to assess them, and there is a quite high risk of bias throughout the studies. So, a conclusion: individual urinary biomarkers can be used with fair accuracy. A combination of urinary biomarkers provide a good discrimination of high-risk patients, and also using clinical models together with urinary biomarkers can also lead to good accuracy. As an implication for research, research for non-urinary biomarkers accuracy is probably not recommended, and novel biomarkers should be identified for this purpose. We are done with the manuscript. We are preparing the supplementary material currently. And my second project is a protocol of a single-center randomized control trial. It's perioperative liraglutide for optimal glucose control in open aortic aneurysm repair. So the main problem is that perioperative hyperglycemia is associated with adverse postoperative outcomes. For its treatment during anesthesia and in the perioperative period, the treatment of choice is intravenous insulin, which carries the risk of hypoglycemia, which can be detrimental in case of patients under general anesthesia. So glucagon-like peptide-1 receptor agonists have been investigated in other settings because they improve glycemic control without the risk of hypoglycemia. So our plan is to create a randomized control trial with diabetic patients who undergo open aortic aneurysm repair. One arm would be patients who get preoperative liraglutide plus minus insulin. The comparator will be placebo plus minus insulin, and the outcome will be the serum glucose levels intraoperatively and postoperatively, and also secondary outcomes like infection, delirium, MACE, AKI. So we are planning to include elective open aortic aneurysm repair patients with type 2 diabetes. And one arm will get the liraglutide subcutaneously before the surgery and at the induction, and the other arm will get the placebo plus minus insulin. And our primary outcome will be time spent in normal glycemia intraoperatively and postoperatively, the total insulin requirement, and episodes of hyper and hypoglycemia. We are clarifying the protocol right now. So these are my two projects. We are planning to submit the article in September. Thank you for your attention. Science knows no country, because knowledge belongs to humanity and is the torch which illuminates the world.
Thank you very much. I have a few questions. First, the data you showed about the combination of the two markers, very promising. What do they do in the urine?
Sorry, I can...
What do those molecules do in the urine? So what is the physiological role there? Are they there because of filtration and they just...
Can I go back and show them? So there are different urinary biomarkers. One of the mostly researched is NGAL, which is an early damage biomarker in the kidney. It's produced in the nephron, in the tubular cells. So it is released as an early damage biomarker. There is another one, which is the TIM. For example, the TIM2 with the insulin growth factor binding protein 7, it's a combination. They are measured together. It's a renal cell stress biomarker, which are released even at an earlier phase. They are released when the cells are sent into G1 cycle arrest. And so these are early damage or renal stress biomarkers, most of them. The kidney injury molecule, the KIM1, is also an injury molecule related to early damage.
Another question, so how often should they be monitored? I mean, should they be checked daily or in every hour? Or
so as probably this, So these are measured, all the data which we gathered are either measured preoperatively, intraoperatively in several time points, or in the early postoperative phase, which is post-op 6 hours. So according to our data, the most useful is measure them intraoperatively or in the early postoperative phase, so 6 hours postoperatively. These are the most sensitive time points.
Thank you. Any other questions?
It was interesting as always. I was thinking that outcome measure is AKI, which is measuring the kidney injury clinical signs, but also lab science maybe. But maybe why those sensitivity markers are not so high, that the kidneys are damaged, but they are not reaching a point to the patient become in an acute injury definition, right? So maybe the sensitivity is still good for these biomarkers alone or in other combination, but because the kidneys are damaged, but they are not reaching a point when there is a clinical sign.
Yeah.
Maybe without AKI, they can be useful as well, right? Or can any other outcome measure be used?
So you are absolutely right. There is a new classification proposal for AKIs which do not reach the level of the classical category of AKI 1, according to KDIGO, but the biomarker positive, but AKI KDIGO negative class. What we should do with them, we don't know, because usually they don't progress into AKI at all. It's reversible. So we can observe them, but these patients will not develop AKI in the later phases. So I don't know the practical use of it, but you are right.
Those are the biomarkers.
Yeah. So the new consensus, which was published last year, says that we should use biomarkers, but they don't specify which one, because we don't know which one to use.